Good morning and welcome to my YouTube channel, Pain Free Partha. Listen to this, subscribe to this, until the end listen. So today's talk is about anesthesia for off-pump CABG. Now you should understand, first my declaration is, I am not a big cardiac anesthetist. And the topic is not going to be for an cardiac anesthetist. The topic is mainly focusing on a person who is going to have an exam for MD anesthesiology or going to work as an assistant in these type of cases. Now, whenever I talk something on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar. So, Director of E-Learning in Mahatma Gandhi Medical College, Sri Balaji Vidyapeeth, Pondicherry. So, when you go to the history of, I'm not going to the detailed history, it is there big, some 10 slides will be there. So, what I want to tell is, see here, Weinberg procedure involved direct insertion of left internal memory into the myocardium. Directly into that, even without the support of heart lungs. And he described a coronary endoptectomy. Now in the 1990s, it increased and possibly now more globally. Now, if we want to go to the directly to the CABG, I just want to say this is coronary artery, which is dividing into right coronary artery and the left coronary artery. What we tell in coronary is this area is as left main. This is RCA. This is left main. We don't tell as LCA. We tell as left main. Then we call this area as LAD, left anterior descending. This area is left circumflex. So the left coronary artery divides into LAD and LCX. And the LAD gives off so many marginal arteries and diagonal branches. Sometimes they are called obtuse marginal. They go in an obtuse way. Now we can see here the RCA divides into right marginal artery and gives off the posterior descending artery. So in routine cardiac anesthesia, PDA is patent ductus arteriosus. But here, if the cardiologist tells PDA, that is posterior descending artery. That is what we should tell. No. So here you can see this posterior descending artery. Can we see from the anterior? No, we cannot see. In the posterior view, we can see the PDA. Why should the need for it? According to the recent data, see here 1.5 lakh procedures and 2 lakh in UK and 5 lakh in US. So many off-pump CABGs are being done. So what is this actually? Coronary artery bypass graft. Now we can see here is the plot. Here is the plot. Now you see from the left, this is the left internal mammary artery. We are harvesting and putting it here. From the left subclavian, the lemma comes out, and this is being grafted into a portion of LAD, that is left anterior descending, distal to the plot. This is what is called bypass. We don't do bypass from here to here. Bypass is from here to here. Now this is the internal mammary artery of the other side. It is going to the right coronary artery, RCA. And this is the saphenous vein. If we have a saphenous vein separately taken out, it has to be put in the aorta in one side and the LAD on the other side. So this is saphenous vein graft. This is the rima graft. And this is the lemma graft. So this is quadruple bypass. So many things are being bypassed. Which vessels are normally used? We use saphenous vein, we use right internal mammary artery, we use left internal mammary artery. Sometimes they may not be enough. So right internal mammary artery being joined with the radial artery go into the PDA, posterior descending artery. So this is how common uses are saphenous vein, right and left internal mammary arteries and the radial artery of both sides. When we use this machine, it is called on-pump CABG. When we don't use it, it is called off-pump CABG, what we call as beating heart bypass. So the heart continues to beat, we do the bypass. That is called off-pump CABG. When you do with the machine, it is called on-pump CABG. Now, usually they call DVD, TVD and all. So double vessel disease and triple vessel disease. So what are the three main vessels? So this is the RCA, right coronary artery. This is the left anterior descending. This is the left circumflex. Okay. If these are blocked, then you call it TVD. If two out of the three are blocked, you call it as DVD. This is the common interpretation. When we should not do this off-pump bypass. Cardiogenic shock. Already the patient is in shock. You have to go on pump only. Major cardiac arrhythmias. There are relative contraindications. Deep intramyocardial target vessels. How can you do a beating heart? Calcified target vessels. Poor function of LV. Patients with the deep extracardiac. Heart is leftward displaced. Sometimes reoperation. There are certain changes which has come up because of the technological advantages. Patients have been done off-pump CABG with arterectomy, with aortic aneurysm repair, with lung surgeries, etc. So there is a difference now. If you want to do a valve repair, double valve repair with bypass. So sometimes we can go on bypass and do both. But we can do also off-pump CABG and then go to pump and do valve repair. Pump time will be less. So this they may call as hybrid. Multi-vessel grafting. So usually what they do, they cut the sternum, open it. Median sternotomy. What is the advantage of sternotomy? We can easily find the PDA, we can easily find the RCA, we can easily find the left circumflex, etc. And we can also see the internal mammary artery. If we want, we can go into bypass immediately or pump immediately. So multi-vessel disease, on pump is easy if you open like this. But if you do like this, are not laterally open, and we cannot do multi-vessel. Single vessel we can do, and it is very difficult to go on pump if an emergency need. Anesthesia management. Now we know what are the things to be done, like in a surgical point. I will come back to the intense surgical points little later. A preoperative evaluation does not differ. That is very important. We have to see the patient, whether they have got a previous operation, whether they have got sugar, BP, diabetes, wheezing, anything, thyroid, all these things have to be corrected and cleared. We need to evaluate whether this Allen's test, we can see whether this RIJV can be cannulated. All these things have to be taken. Good IV access, all these things have to be done. Preoperative evaluation doesn't mean the cardiac evaluation, doesn't mean we need to miss a difficult area. So that is also to be done. A routine examination with a cardiac evaluation. I am not going into the details of so many risk indices. So many risk indices. That's a different chapter. So I'm going to go mainly closely on some technical aspects only. All these things matters. Whether this patient can take up, go NYHA, New York Heart Classification 1 and 2, fine. 3 and 4, careful. So these things, risk index, have to be taken care of. Now, what are the things? Beta blockers have to be continued. Propylate have to be stopped. AC inhibitors preferably stopped. LMWH can be started and stopped. And aspirin can be continued. And electrolytes can be done. So this is the simple. Beta blockers, aspirin continue. Propylate stop. AC inhibitors stop only 1 day before. Low molecular weight can be started. Yes, unfractionated heparin 6 hours prior to surgery can give. So some institutes use epidural also. There are a lot of doubts about this. Previously, we used to do what is the day before only we will put the epidural. Thoracic epidural the day before the operation. Because on the day of operation, if you have trauma and if the patient goes on to heparin, there may be problems. So what we do is put the epidural the day before. There are a lot of studies which say Just for early extubation, there is not much of a big advantage with epidurals. Now we start invasive lines, give some fentanyl and whatever it is, some narcotics, and start local with right IJV, femoral and or radial. People start femoral also sometimes because in sick patients, sometimes if you want to do IABP, there we can do easily intra-aortic balloon pump if you have a femoral. So people start femoral first of all, and there are people who start only radial, and if need, they start an additional femoral. So fentanyl or morphine and midazolam. Usually there are three pumps ready. One is NORAD, another is dopamine, another is NTG, and the NTG is on started in a very low dose. And put the tube after vecuronium and lignocaine, and etomidate or propofol, and sternotomy, we know additional fentanyl in lung now. These doesn't change. Now, by the time they start, somebody else is doing this. Two set of people are starting to take the bilateral saphenous graft, and the saphenous graft are sometimes poured in papaverine solution as a vasodilator. Now we can also see this being the graft lemma being slowly taken out, and here we can see the aorta is partially clamped and a hole is put so that from the aorta this saphenous vein will go into the artery from here to here. Now there is a graft going from here to here. So now it's a single from here, double from here. This is a saphenous vein graft. That's what the puncture is done in the aorta. And triple vessel disease, here you can see this quadruple. Now Lima to LAD, this is the octopus machine which stabilizes the heart. The Lima is being grafted from here. It is on the chest wall from down. They will go down and graft the Lima. Then they will, all small clamps, they will clamp all the branches and see, open it and see whether there's a good flush of blood. And then they will grafting into the belly. Now this is the octopus machine. Whatever it is, the basics don't change. We have to maintain good oxygen supply and we have to decrease your demand. So that is what is important. So heart rate down because diastolic time increases so that the blood flow increases. Aortic diastolic pressure increases. Preload slightly on the higher side and afterload reduction. The hemoglobin should be correct and your PaO2 should be good. So coronary artery diameter by way of small dose of nitroglycerins. So this doesn't change. Heart rate is high means it is bad for the heart. Now monitoring is saturation, capnometry, ECG with ST analysis, transesophageal echo, temperature, invasive BP, CVP, clotting, and urinary. These are the basic things which need to be done. Coagulation. Right femoral artery was catheterized for IABP. Pulmonary artery catheterized. Pulmonary arterial PAC was put in patients with impaired cardiac function in pulmonary arterial hypertension. Now, usually midline sternotomy, beating heart, yes, very important. In bypass on pump means the surgeon can go ahead. The beating heart means the surgeon and anesthetist should talk, should good communicate each other. Stable because the rhythm in an environment that causes rapidly. The heart is, they will rotate the heart and do the circumflex. They will rotate the heart like this and do the PDA. So all these things, we should be seeing what the surgeon is doing. And the surgeon should manipulate the heart and see the blood pressure, what is going on. Now the cardiac manipulation is like this. And this is what is called a starfish. And it fixes the heart. Now you can see the starfish. Now, when the BP comes down, there are a lot of things. When there is a manipulation and the BP comes down, with manipulation, they cannot operate. So, hemodynamic compromise is usually done by Trendelenburg positions and some fluid and some vasoactive. You are ready with NORAD and dopamine, no? Push in NORAD for some time and then do a head round and then give some bolus of 300, 200. So, CPB should always be immediately available, but this is what we routinely do. Now you can see the anatomy of RV, LV, everything is normal. But if you put the octopus and rotate like this, everything is displaced, you cannot see anything. Now if you give a Trendelenburg position, you can see some flows. The pericardial traction sutures are taken, and if it is tight enough, sometimes we may loosen it. And if there is no pericardial traction sutures, it is difficult to rotate and do all these things. So that is very important to take out the pericardium and suture it. So otherwise, it is difficult to move the heart and push the other graft. Now you can see this is the pericardial suture being taken by the surgeon. So unless this is done, pericardial suture is done, it is difficult to move behind. Graft and collateralized vessels and the collateralizing vessels. So this is the collateralized vessel and this is the collateralizing vessel, which is collateralizing. Intraoperatively, yes, fluids, vasopressors, inotropes and surgical position correction is slow. Or in cases of MR, where vasopressors may increase. See here. Preferably give fluids, Trendelenburg and vasopressors. Vasopressors means NORAD. But you have to give dopamine where you think MR is a problem, because vasopressors will increase SVR, which will cause problems in mitral regurgitation. So we may need to give dopamine, somewhat reduction in SVR, so that the MR is better. Map down to 60 when you are partially clamping the air. That is very important. So because otherwise it will be very difficult. So otherwise it may be around 70 to 80 millimeters map. Temperature, because you don't have your bypass machine on pump which will maintain the temperature at 33 or 34. We have a heating element there, but here we need to maintain. Fluids, the full cardiac chambers, if the heart chamber is full, how can they operate in position and all? So that should be there. So many institute average 1.2 to 1.5 liters per surgery. Crystalloids are better. Many then don't use colloids, but prefer if there is a blood loss to give PRBCs. So check CVP, urine output, blood loss, TE, and administer IV fluids. So here ACT is there. Normally it is less than 100. Activated coagulation time. So that is around 250 to 300. People use only 100 to 200 units. And some people may target 400. It is preferable to keep around 250 to 300. And strong antiplatelets post-op and protamine, yes, in many centers. So there are three problems. Now we see, if you want to work on the posterior and lateral surface, the heart has to be lifted up and paralyzed. This displacement can have significant cardiac. That is what I told again. Sometimes we need a vertical position from this. So sometimes the right atrial pressures are higher, because the left atrial pressures may be high, because the heart becomes like this. Now you see here, every pericardial retraction suture, obtuse marginal, how the heart is rotated, OPDA, how the heart is rotated, plain LAD, the heart is there. So these positions, sometimes if you do like this, the BP will be 80-40. Again, there may be a positional mitral regurgitation. That's what I told. Fill up with fluids, Trendelenburg, vasopressors. If you have MR, you give some amount of dopamine. If you don't have MR, heart rises esmolol. If it falls, temporary pacing wires in RE. So it is preferable to have MAP around 70 to 80 with a MAP by heart rate of more than 1. If the MAP is 70, then your heart rate should be 65. If a MAP is 80, you can have 75. So more than 1. Sometimes if we do RCA grafting, we can have bradycardia. So we should have pacing ready. Many times the pacer will be in the anesthesia machine and things will be given to them immediately. So sometimes atropine will help, sometimes pacing will help. Some institutes use cell salvage techniques. So usually around 9 grams or a hematocrit of 27, we can use these things. The criteria for a fresh frozen plasma, prothrombin time is 1.5 with the diffuse bleeding. Only the PTINR with the diffuse bleeding. Extensive strategies to prevent, yes, pericardiotomy. Sometimes they do a right pleurotomy also. Ischemic preconditioning. What is that? If you are going to block completely a vessel, now what you do is, or the heart, slightly clamp, slightly make ischemia. So the heart conditions itself for the ischemia. This is what is called. I'm not going to the details. This is what is called. Ischemic preconditioning is a separate topic. So ischemic preconditioning, electrolyte optimization. So we want MAP to above 70. MAP by heart rate is more than 1. Avoidance of the surgery on main RCA, instead grafting its posterior mesenchymal if you have problems. Pacing wires may be prophylactically sited at the right age. Sometimes IABP can be kept. If you think the hemodynamic stability is going to be dangerous, ready with an IABP, intra-aortic balloon pump. NTG with adrenaline, NTG with NORAD, NTG with dopamine, and melrinone infusion, and some institutes use methoxamines. Now we know the aorta one is going to come and we are going to put in failure. And if you keep it, you have to clamp it. No, if under clamping time of the LED, sometimes ischemia. So that is what they put a tube like this. They call it a shunt. And they connect the aorta from here and suture it. One suture is less, remove this and suture the whole thing. Remove this shunt and then suture it. Transesophageal picks up regional fall motion abnormalities. It can also tell us about the fluid status. We need to monitor urine output. This is a very simple sign of good cardiac output. Urine output is a very simple sign of good cardiac output. Now you can see this. Simply you can see the TE is there and the machine is showing this. We can see if there is any MR and accordingly treat it. Yes, now we have bypassed it. Patency testing is usually clinical. Venous is usually reversed because valves will be there. Saphenous vein should reverse. Connect DR and push blood with syringe. Connect DR it, remove air and push blood with syringe. Yes. Arterial lima clamp anastomosed. Open it. Now from the LED, there is small amount of blood going because of the reverse flow. Yes, that means your grafting is fine. Your graft is patent. There are certain techniques used like transit time, fluorescent imaging and all, but most of the institutes use clinical patency testing. Consciousness, hemodynamic stability, dorsalis pedis. I used to see dorsalis pedis. If that is well felt, then your output is fine. CPAP for 1 or 2 hours, fentanyl infusions, IV paracetamol, and extubate with preferably after reversal. So you should be conscious. The hemodynamic stability, sometimes they may be on NORAD and NTG. Dorsalis pedis, artery CPAP for 1 or 2 hours and use fentanyl and then IV paracetamol. Give a good pain relief, then take out the tube after reversal. Now, why should we confuse like this? Why can't we do on pump only? Why should the surgeon be difficult? There are lots of controversial things. The overall mortality is less scoring. Coagulation is definitely better. We need not give so much high doses. Extubation is earlier. We have found out the cognitive dysfunction and stroke is less. The inflammatory biochar markers that comes out after a bypass machine is less. The blood needs are less, but they have similar graft patencies and cost is less. So can we use in patients with multiple comorbidities? Yes. Fast track anesthesia is a logical extension of OPCAP, off pump CABG, because of the improvement in anesthetic techniques and better myocardial deambulation, early extubation, early discharge, preferably extubate before 8 hours. Sometimes if you have an epidural, you can use fentanyl with dilute local anesthesia or fentanyl infusions, even diclofenac or ketorolac. You can also use fentanyl patch at the onset of surgery, because patch will not start to work immediately. We may need to give time for the patch to work. What is hybrid? That is already told. Mid-cap, a minimally invasive direct cap. PCI with CABG. LAD lemma off pump plus RCA in marginal stretch. Non-LAD areas. So a lot of hybrid things going on. Now you can see a minimally invasive bypass off pump requires lung deflation on the surgical incision. Sometimes we need to deflate the lungs here. Some people use even WM tubes for off pump bypass surgeries like this. Totally endoscopic coronary artery revascularization. Robot is very costly. Then we came up with endo-CABG, uses thoracoscopic and non-disposable instruments. So non-disposable means it is cheaper to harvest the lemma. Coronary anastomosis, we use a thoracoscopic, harvest the lemma and connect it to LAD. So this is surgeon's experience and patient selections. So it can be done as thoracoscopic procedure also. Conversion to on pump is, they say, is 8%. More complex lesions, tolerance and stabilization of verticalization. What they call is verticalization. If you start to move like this, the left atrium and left ventricle become more vertical. Pump is to be ready for all off pump cases. Now we have more than 15 minutes. If you have a cardiac output is less. The venous saturation is less than 60%. Normally it is 75. The MAP is less than 50 for 15 minutes. ST elevation is high. Large new wall motion abnormalities sustain the malignant rhythm disturbances. All these things, yes, we need to convert it into on pump. So cardiac, yes, basically the output is less. The heart is not functioning properly. Contractility, whatever it is, it's not good. So we may need to go on pump. Without pump ready, then yes, it should be like this to start and off pump CABG. Somebody, yes, a pre-op examination should be complete as a routine case. You should understand what are the vessels problematic, and you should have a good cardiac examination. Good communication between the surgeon, anesthetist, and the cardiologist is needed. What is going to be done? Avoidance is a good, smooth induction, maybe with etomidate, vecuronium, and whatever it is, smooth intubation. So basically, our management should be focused on myocardial balance, myocardial accident. Here we have a demand of heart rate and all. Here we have a demand of preload contractility and all. So good, normal good contractility, good oxygen supply, rate is less, but diastolic time more, coronary vessels are slightly dilated with NTG. All these things matters. When you move the heart, we need to give Trendelenburg position and give IV fluids and give NORAD. And if you have a problem with MR, add slightly dopamine. And then wait. So we have all the procedures should be known. Extubation early as possible because adequate post-op pain relief like a fentanyl infusion or a patch with a diclofenac, sometimes with an IV paracetamol. There are two things which need to be managed and vigorously intraoperatively. One is urine output and the other is temperature maintenance. Thank you. Visit me at Pain Free Partha. Thank you all once again.